Hi, welcome to week 3. We're going to cover chapter 21 on the vessels. Okay? This lecture will be a little bit more on the lecture rather than laboratory. The laboratory will still go through, and I'll point out some major things. But the first thing I want to do is just kind of get into the chapter material, just to explain the anatomy and the physiology. So the first thing we have is we have to talk about the vessels and the vessel types that there are. Coming from the heart, okay? Large vessels going away from the heart, under high pressure, very thick walls to them, they're called arteries. Okay? And there are elastic arteries, which are most of the named arteries that you're actually supposed to find in your objectives. Once you get to the very smaller arteries, like only a couple millimeter arteries, then they are considered muscular arteries. And so eventually they get to very, very small arteries. The smallest of the arteries are a special type of vessel known as arterioles. So arterioles are small vessels, small diameter vessels, taking blood away from the heart. Those arterioles will enter into a capillary network, or what I like to call a capillary bed. In the capillary bed, we have capillaries, very, very thin-walled vessels, very good at performing their duty of exchange with the tissues. Of your capillaries, there are several different types of capillaries. You can see in your notes on the capillaries, but basically the two major categories, you have continuous capillaries and you have fenestrated capillaries. Continuous capillaries are going to be solid endothelium versus the fenestrated have little fenestrations or little pores, little gaps in them. The continuous capillaries are usually found in muscles or possibly also in nervous tissue. For example, you would need a continuous capillary in order to form tight junctions to form the blood-brain barrier. There it makes it a little bit more selective barrier. The fenestrated capillaries are very, very good at exchange, so you're going to see these fenestrated capillaries in areas of the body where you have secretion, absorption, or even filtration. For example, secretion. So you'd see this capillaries in the endocrine organs. You'd see them in the, if you remember from A&P1 on the eye, the ciliary process to the eye. If you remember from A&P1, also in the brain, choroid plexus creating the CSF in the brain, and so it's secretory. Absorption, you'd see the fenestrated capillaries in the intestinal walls, intestinal villi, in order to absorb the nutrients. We'll get to those chapter 24 in a couple chapters from now. Also, fenestrated capillaries in the kidneys, where you have a filtration membrane in the what we call the glomerulus of the kidney nephron. Another type of vessel, okay, that we have coming out of the capillary bed is going to be very, very small veins. They're called venules. Okay? And then the venules will drain into larger veins. Now, the veins are large diameter, and they're going to be a little bit thicker walled than, let's say, the capillaries, but they're not going to be as thick walled as the arteries. And the reason why is because it's just not necessary to do it, because if you remember from the heart generates the pressure, and blood is going to flow from high to low, which means that your highest pressure vessels are going to be your arteries, then followed by your arterioles and capillaries, then venules, and your veins are actually the lowest pressure vessels you have. Very, very low pressure. To give you an example, maybe mean arterial pressure might be 80, 90 millimeters of mercury coming out of the arteries. When you get to the capillary bed, the front end or arterial end of the capillary bed will maybe be 30, 35, maybe 40 millimeters of mercury. When you get to the end of the capillary bed, maybe down to 15. And by the time you get into the veins, you're at between 0 and 5 millimeters of mercury. So very, very low pressure. Because we have low pressure in these vessels, it's tough to get the blood to actually flow against gravity. And so one of the modifications that veins have valves. They're little one-way valves so that you would have one-way flow even under low pressure. Also, the veins, when they're getting very, very close to the heart, are very, very, very low pressure. We're talking in the subclavian vein as it's going in the heart. is practically 0 millimeters of mercury, and this is a good place for the lymphatic system to drain into. We'll get to that in chapter 22. Okay, so we have arteries basically trying to put blood under pressure, get it quickly out to the tissues. Then the capillaries would be very, very thin-walled, good site of exchange with the tissues, and then you have the veins trying to collect all the blood back and then eventually get it back to the heart. Okay. A couple other vessels we have. If you see in your notes, you'll see medarterials, which are entrances into the capillary network. And there are also special vessels. They're called anastomoses. An anastomosis, okay, is a direct merger of two vessels. And we have two major types of anastomoses. There's an arterial anastomosis. An arterial anastomosis is going to be a direct merger of two arteries. Now, typically arteries will branch and radiate out. You don't have too many cases where you'd have arteries merge together, but they do in several places, and I'll talk about these a little bit later. One example would be in the brain, in the circle of Willis. Also in the heart, you tend to have collateral vessels that will anastomose. And what this does is gives it, going to one tissue, you have a couple different routes. Then that way, if something gets blocked, you have at least a detour around that blockage. So that would ensure constant blood flow to that area. Another type is anastomosis in our arteriovenous anastomosis. And arteriovenous anastomosis is actually a direct merger of an artery and a vein. And you actually bypass the capillary bed. Now you have these little arteriovenous anastomoses plus these little thoroughfare channels in the capillary bed, basically to bypass the capillary bed. Because what happens is, in your tissues, if you're using them and they have a high metabolic rate, like let's say if you're running and you're using the muscles in your leg, then you would want lots of what we call vasodilation, where the muscle, smooth muscle in the vessels, okay, in the arteries, especially the arterioles, would dilate, and then you would get more blood flow into the capillary bed. And then in the capillary bed, there are these structures, basically small bands of smooth muscle that can also relax and dilate. They're called precapillary sphincters. And so those will open up more blood flow into the capillary bed when you need it. Sometimes you don't need all that extra blood. So let's say while you're running, you have all this extra blood going to your muscles, you have a lot less blood going to your stomach and your intestines. So the capillary bed in the stomach and intestines, you'd see vasoconstriction, okay, where the smooth muscle actually contracts, and that will divert blood away from the capillary beds and in through those thoroughfares or through those arteriovenous anastomoses. Okay. All right. So we talk about different vessel types, a couple little modifications there. There are a couple others. You have to look at portal system, vasa vasorum. Those notes are in the PowerPoints. But I want to just go over a couple things as far as structure. First of all, with the artery and vein vessel structure, they have three layers to them. They say that there are three tunics. There's a tunica intima, it's the innermost. There's a tunica media, it's the middle layer. And then you have a tunica externa, the outer layer. The inner layer is going to be your endothelium, connective tissue, and arteries. Elastic arteries are going to have a lot of elastic tissue to make them very strong under pressure. The middle layer is mostly muscle, so that's your smooth muscle. And then you have your tunica externa is going to be connective tissue, sometimes called adventitia, is basically to hold those vessels in place in the connective tissue or in the tissue or organ that they're in. When you look at a cross-section of an artery versus a vein, the arteries are going to be a little bit thicker. You're going to see lots of tunica intima and tunica media, strong-walled, to hold that pressure. The veins, they're not going to have as much of that thickness there. They tend to be a little bit thinner. They'll have a pretty predominant tunica externa to kind of hold them in place in the tissues. The other thing that you'd see in veins are going to be the one-way valves, which are basically just flaps in the tunica intima. Okay. Now, a lot of times when you hear about vessels, as far as clinically, you talk about vascular disease, coronary artery disease, those kind of things. You may have heard these two terms, arteriosclerosis and atherosclerosis. Now, there is a difference between those two terms. First of all, and a lot of times they're used interchangeably, but here I just want to go over the differences between them. First of all, arteriosclerosis is a general term for what I call the hardening of the arteries. With age, your arteries are not going to be as elastic. And so they're not going to be as flexible, they're not going to be as what I call not as compliant, which means under pressure they're not going to expand very well. And everyone's going to have some degree of arteriosclerosis with age. With the arteriosclerosis, what happens is if you have less vascular compliance, then you're going to have the pressure in the arteries will tend to go up. And you may see this with people who might have pre-hypertension, stage 1 hypertension, that usually with age their blood pressure is just going to go up a little bit gradually, and some of that is due to arteriosclerosis. Now the other term is called atherosclerosis. Atherosclerosis is the buildup of plaques in the walls of the vessels. So I have a model here. It's kind of showing what's going on. Okay. Here, in this type of artery, if you have an artery that looks like this, where it's clean, wide open, no plaques, with age you could still get arteriosclerosis. Okay? However, with age, sometimes you will have cholesterol plaques will start to build up and possibly occlude the artery, but as these plaques are starting to build up, these plaques will cause arteriosclerosis. But the buildup of these plaques is called atherosclerosis. So, arteriosclerosis is going to happen to everyone with age. It can be exacerbated by atherosclerosis, which is the buildup of these plaques. Okay, so hopefully that clears up those two terms. All right, now I want to go on to, as you're reading in your book or you're looking at your PowerPoint notes, I want to go into a couple areas where we have some what I call special circulation. Special circulation. Now, it's basically just some interesting areas of the vasculature that I want you to be aware of and know about. And so what I have is, last week in my lecture-based class, I wrote these on the board. And so what I'm going to do is I took pictures of the notes I wrote on the board, and I'm going to show them to you. And you can pause the video and write down the notes here. And so we have 5 areas of special circulation, what I like to call it. First area I want to talk about is the fetal circulation. Okay. Now some of this you may be aware of because from chapter 20 we talked about it. So here's fetal. Okay. Right there. Hopefully you can read it. Okay. But I will talk about it here. So the fetal system, basically, what you have is the lungs are not being used for gas exchange. You're going to get the gas exchange through the placenta. So what you have to do is you want to bypass the lungs, because when the blood is coming up from the vena cava, that's already oxygenated blood, and then you got to get it over from the right side of the heart over to the left side of the heart. So what do? Well, basically you have these 2 shunts. You have the foramen ovale that becomes the fossa ovalis, okay, which is I think I had shown before in chapter 20. So we have that foramen ovale right here in the heart. Okay, there. That becomes the fossa ovalis. We have the ductus arteriosus, which becomes the ligamentum arteriosum, and that's another shunt. Okay. And then when you have, blood coming in the fetal circuit, you actually have an umbilical blood supply from the placenta. Okay. Let's say to and from. You have 2 umbilical arteries. Now, umbilical arteries mean the fetus has 2 vessels going from the fetus out to the placenta. Going out to the placenta, that would be deoxygenated blood. So they're umbilical arteries, but they're deoxygenated blood. So there's 2, when I say blue vessels, they're colored blue on the model, coming out. So they're showing here on this model, in the cord, you see 2 blue vessels inside the cord, okay? And coming out, deoxygenated blood. The blue vessels are your umbilical arteries. Your umbilical vein, you only have one of them. The umbilical vein is your lifeline coming in from the placenta. Umbilical vein comes in. Now the umbilical vein, when it gets to the fetus, we have the umbilical vein then goes into right by the liver. And right there, that umbilical vein is called the ductus venosus. And so the umbilical vein, it's red, oxygenated blood called the ductus venosus. It hooks right into the vena cava, right at about where the hepatic arteries are. And that's where it comes in. You can see the umbilical arteries are going to be here. Okay? Two of them here. So two blue umbilical arteries carrying deoxygenated blood, one umbilical vein carrying oxygenated blood from the placenta back through the ductus venosus and then into the inferior vena cava going up to the heart. Okay, so that's the fetal circuit, and that's one area of special circulation. The next area is in the brain. In the brain, we have a structure, it's called the circle of Willis. The circle of Willis has arterial anastomoses that ensure constant blood flow to all areas of the brain. Your major vessels supplying the brain, okay, are going to be your vertebral arteries, but mostly the internal carotid arteries. And so the internal carotid arteries, there's a left and right, okay, they go into a arterial circle. So all these vessels, these vertebral arteries, they all come in and anastomose into this circle. Now let me show you this, and I can show you a drawing that I made, okay, of the circle of Willis. Okay, and it's kind of showing it. The one thing I have to point out is right here, this would be like if you're looking down on the brain, this would be the internal carotid arteries would be here and here coming up in. Then you have the vertebral arteries here coming in also. The vertebral arteries right away anastomose into the basilar artery. Then you have all these arteries will anastomose into this circle. And what can happen is, because this circle is open and you can get blood flow around this circle, if you close off an internal carotid artery, okay, close it off completely, you can still perfuse the entire circle using the other internal carotid artery or that basilar artery from those two vertebrals. Okay. Let me show it to you in the skull. Right here. So we have the vertebral arteries coming up into the basilar arteries. Now these are cerebellar arteries. I didn't show them on the drawing, but the basilar artery comes up into the circle, and then we have right here we have a posterior cerebral. Then we have the two. If I can show it to you here, right here and here. Those are the posterior communicating arteries. Connecting, you have an internal carotid artery, and then it makes this turn out here. This is the middle cerebral artery here. And then anteriorly, we have the anterior cerebral arteries. Okay? And then this little crossbar right here, this is the anterior communicating artery. The majority of the circle is made by your cerebral arteries. So you have the posterior cerebral, the middle cerebral, the anterior cerebrals here and going up. You just have a little bit of this circle made up by the communicatings. They're just little connectors. You have an anterior communicating here, and then you have the two posterior communicating here and here. Okay. These little ones here are actually optic, little branches off the internal carotid right there. They're not technically considered part of the circle there. Okay. So that's the circle of Willis there. Okay. All right, in the heart, this is number 3. We have the coronary arteries, and these coronary arteries do have collaterals, and then those collaterals anastomose. So you have arterial anastomoses in the heart trying to supply all the areas of the heart. So if there's blockage, hopefully you don't have an area of the heart start to die. Okay. All right. Now, the brain, the heart, they're pretty straightforward as far as arterial anastomoses, trying to maintain constant blood flow. Okay, so here is the notes for the brain and the heart. Okay. The fourth one, okay, there, is a portal system. Now, a portal system is actually a vessel that directly connects to capillary beds. Normally, say if you have capillary bed going to your index finger and your middle finger, okay, these are separate capillary beds in these fingers, that you would have an artery going out to the capillary bed. Then you have your capillaries, and then the vein would go all the way back to the heart. And then to get to this capillary bed, same thing. You'd have artery, capillary bed going all the way back to the heart. To get blood to go from this one to this, from this finger to this finger, if you have a blood cell going from this one to this one, it has to at least come back to the heart. There's no way to go through the hand and get to the next one. They're not connected. Okay? But in a portal system, you do have two capillary beds, and they are directly connected. Okay? Best example is the hepatic portal system. The hepatic portal system has the hepatic portal vein, which basically just connects two capillary beds. So you would have first capillary bed, okay, either in the stomach or the intestines, going into the portal vein, and then that goes directly to the liver. Okay. Then from the liver, then it goes back up to the heart. So what happens is everything that you absorb through your digestive tract, in your stomach and your intestines, is going to get absorbed not into the veins and back into general circulation. It gets absorbed and taken into the portal vein, hepatic portal vein, and then that goes directly to the liver. So everything you absorb has to go through the liver before it can get out to general circulation. And so the liver is kind of like a nice checkpoint for anything that you bring in. And so it's kind of like if you were coming into the country, the liver would be like customs and immigration, where you'd have to go through that once you get in before you're allowed out, into, let's say if you're coming in from the airport, out into the rest of the airport. And so the portal system is one that connects these two capillary beds. Another type of portal system is a very short portal system, is between the hypothalamus and the pituitary, where the hypothalamus can secrete releasing hormones in very, very small amounts, and they go directly to the pituitary gland without being diluted into general circulation. So you can actually have hormones secreted from the hypothalamus directly into the anterior pituitary, and the anterior pituitary would then release hormones or not release hormones depending on the releasing or inhibiting hormone that is released by the hypothalamus. Okay. Another type of portal system you'd see in your book, they'll talk about the in the kidneys, where you have a glomerulus as a capillary bed, and eventually that portal system, you have a portal vessel going into the second capillary bed, which are the peritubular capillaries and part of the vasa recta. I'll get to point that out when we do chapter 26 on the renal system. Okay. Then number 5, the lungs. Okay. Now this circulation here is kind of like I'd say special circulation physiology. Still important. The lungs, it says here, in most tissues, if you get a decrease in oxygen levels, this is going to cause vasodilation. So you get more blood to the tissues. You want to get more blood, more oxygen to the tissues. This would be like if you are running, say, and you're using your muscles, and the muscles are using up oxygen. So they're sucking up oxygen, and your oxygen levels are starting to get low in your muscles. Let's say if you're running really fast, and you start to have some of that, we say, cross over that anaerobic threshold. And so all of a sudden, then you have low oxygen levels, and you need more oxygen. What will happen is you actually have some local control over your vessel diameter, so that if blood oxygen levels start to go down, you get vasodilation locally in the tissues, and then that would cause more blood to go into the tissues. Okay, this is very typical. This happens, this local control, and actually most of the control, vasodilation, vasoconstriction, happens at the level of the arterial and the capillary, before the capillary bed, not in your major arteries, because if your arteries, let's say your aorta, can't really clamp down on the aorta. You can't really get vasoconstriction because the pressure is so high. It's not until you get too close to the capillary bed where the pressure is cut down about in half where you can actually get some vasoconstriction and then divert blood to or from an organ. So when O2 levels go down, you get vasodilation, gets more blood and more oxygen to the tissues, trying to maintain homeostasis. In the lungs, the opposite happens. In the lungs, you get vasoconstriction where you have low oxygen levels. And the reason why is because when you inhale, unless you're taking the most deep breath possible, typically you're just bringing in about half a liter of air. It's called the tidal volume. That half a liter is just going to go into the lungs and not going to spread out to all the areas of the lungs. So that little bit of oxygen you bring in is going to be centralized, okay, near the bronchi of the lungs. And so then that's where the oxygen is, so you get vasodilation where the oxygen is, vasoconstriction where it isn't, so that you actually shunt the blood to the more oxygenated areas. Okay? And so basically, you want the blood to go where the oxygen is, you don't want it to go where the oxygen isn't. Example I give is like if you were having, if you were in charge of a bus line, you want to send the buses, right? You want to send the blood, you want to send the buses to where the people are. Okay? You'd want to send it into the more populated areas, not into the more remote areas. Okay? And the same thing happens in the lungs. So this is opposite other tissues where low O2 levels causes vasoconstriction in the lungs. High O2 levels causes vasodilation to shunt the blood over to the oxygenated areas, pick up the oxygen. Okay. All right, so that covers all 5 areas of special circulation. Okay, all right, now we're going to get into a little bit of physiology here. So we'll talk about blood pressure, okay, and these are some formulas, okay, they were in your PowerPoints in Chapter 20, but I cover them in Chapter 21. And what we have is 2 formulas here. We have pulse pressure and we have mean arterial pressure. And these are the formulas for pulse pressure and mean arterial pressure. Now, pulse pressure is just the difference between your systolic and diastolic pressures. So if your blood pressure is 120/80, you just subtract the 2, your pulse pressure would be 40. Now, with exercise, what happens is you actually have your diastolic pressure, okay, when the heart is at rest. The diastolic pressure under exercise does not go up very much. Okay? The systolic pressure goes up quite a bit. So then with exercise, you might see, let's say if your blood pressure is 120/80, with a little bit of moderate exercise, your blood pressure gets up to like 160 over maybe 81, 82. And so what happens is you get a increase in pulse pressure. Okay? And this is evident if you ever try to feel your pulse when you're exercising. It's a lot easier to feel a pulse. You have a very strong pulse when you're exercising. It's because of good pulse pressure. Okay? Now, the other type of pressure formula we have is a little bit more complicated. It's called mean arterial pressure. So I'll show the formula again here. And you can see I did some examples down at the bottom of the page, so you can write those down. Mean arterial pressure. Your formula is 2 diastolic plus a systolic, that quantity divided by 3. Now, you think mean arterial pressure would be the average of systolic and diastolic pressures. So you'd think if a blood pressure was 120/80, the mean arterial pressure, the mean, 120/80, the mean would be 100. But that's not the case. If you do it, you can see the formula here, instead of 100, I got 93.33 millimeters of mercury. You see how the way that the formula is written is that the diastolic is weighted more, twice as much as the systolic. Now, why is this? Well, if you think about the heart cycle, okay, mean arterial pressure, we have to think of the average blood pressure in the arteries over time. And if we're looking over time, you spend 2/3 of the time at the diastolic pressure, 2/3 here, and 1/3 of the time at the systolic pressure here. So it's not the average. Okay? it's actually weighted more towards diastolic. Okay? And so if I ask you why isn't mean arterial pressure just the average between systolic and diastolic, the correct answer is because the heart spends more time in diastole. Okay? It spends about twice as much of the time in diastole compared to systole, and we need to account for that. Okay? And therefore, that's the formula. Okay. All right. The next one, lecture and lab is going to cover blood pressure, and so if you have blood pressure notes here in chapter 21, we'll cover blood pressure with the EKG, blood pressure, pulse, and lymphatic next week. Okay? If you're reading in your notes about blood pressure, pressure alternates in the arteries between systolic and diastolic. Okay? And when you're reading blood pressure, okay, if you use the blood pressure cuff and you pump it up where the meter on there, it's called a sphygmomanometer. When the meter is above systolic pressure, then you're not going to get any blood flow through. If it's below diastolic, then it just lets the blood flow through, not a problem. But when you're in between the two, then you have some kind of intermittent opening and closing of the vessels, and this is going to make sounds, and they're called Kortkoff sounds. And the Kortkoff sounds are what you listen to when you take a blood pressure. And so next week I'm going to demonstrate that in lab for you. Okay. All right. Now the next thing I want to talk about is capillary exchange. I have a little drawing for you to explain capillary exchange. Okay. Now, I would say that the capillaries are something like medium pressure compared to, let's say, the arteries high, veins are low pressure. Because the capillaries are under pressure, what happens is when the blood gets to the capillaries in the tissue and the walls of the capillaries are very, very thin, you have some hydrostatic pressure trying to push fluid out. So you have this blood plasma where the plasma wants to be pushed or kind of strained through, okay, pressure filtered out into the interstitial fluid. And this happens. And so what happens is hydrostatic pressure, okay, because we're under pretty decent pressure here, 35 millimeters of mercury, forces a lot of the fluid out. Now as the fluid goes through the capillary bed, then what happens is the pressure starts to drop. And as the pressure drops over here, now what we have is we pull the fluid out, now we have dehydrated blood here, okay? And then when it's kind of dehydrated, then you have an osmotic gradient here where you have somewhat dehydrated blood, high hematocrit here, and you have osmosis pulling the fluid back in. Okay? The example I would give is kind of like over here, under pressure, is like take a sponge, fully saturate it with water, okay, and put it on a table, okay, squeeze the sponge, squeeze out all the water, okay, that's what you're doing here. Now let go of the sponge real slowly and watch the sponge kind of soak that water back up. Now it soaks the water back up, but it doesn't soak up all of it. There's still a little bit of water left on the table that you take the sponge, dump that, and you have to use some paper towels to clean that up. Well, the paper towels to clean that up is basically, it happens here where you can get 90% back, but you can't get all of it. So what would happen is over time, say per day, if you have about 30 liters of fluid generated, interstitial fluid generated by interstitial pressure, capillary pressure, then you would need to reabsorb it. You reabsorb 27 of the 30, you have 3 liters left over. The 3 liters left over need to be put back into circulation, otherwise you would start to swell. You'd become edematous and swell. So what happens is you actually have another circulatory system called the lymphatic system, where the lymphatic vessels can take up that extra fluid and put it back into the circulation. Now where do the lymphatic vessels do it? Well, we have pressure, 35 millimeters of mercury or so. This is kind of like I just picked round numbers here. Pushing fluid out. Then we get to the end here, 15 millimeters of mercury. So you still are trying to push against some hydrostatic pressure here. And so you can't put it all back. So instead of putting it back here where it's 15 millimeters of mercury, you pull it into the lymphatic vessels, and the lymphatic vessels can put it back into the subclavian veins where the pressure is practically zero. And so that's an easier place to put it back than right here. So it carries that extra fluid away, and then that helps maintain fluid balance, maintains homeostasis. Okay. All right. Now, blood pressure and gravity. You have to pump blood up against gravity, okay, when you're upright. Maybe you've heard of, like, when you're standing for long periods of time, you're not supposed to lock your knees. The reason why you're not supposed to lock your knees is because if you lock your knees, you're using your skeletal system, okay, to support you. If you're using your skeletal system to support you, then you are not using your muscles, and you're designed to use your muscles, contract, and push on the vessels, and push on the veins. And you can push on the veins, and then the veins will use their one-way valves to get blood back up to the heart. So for what we call venous return, you need to have your muscles contracting against the veins. Okay? Then, say, to go back up to the heart, okay, you need the veins, but you also have another mechanism in place to actually bring blood back up into the heart. Remember, the heart is located in the mediastinum in the thoracic cavity. Okay? And when you breathe in and breathe out, okay, what you're doing is you take your diaphragm and you would contract your diaphragm, pull down, make the volume larger, drops the pressure. That negative pressure allows for air to come into the, from high to low, causes air to go into the thoracic cavity. When you create that kind of little vacuum to get air in, you not only make a vacuum for air, but you also make a vacuum for blood, and it actually pulls blood in. So every time you take a nice deep breath, you pull air in, but you also pull blood back up to your heart. And that's called the respiratory pump. So you actually use muscular compression and your valves of your veins to get venous return, and then to get blood back up to the heart, you use what is called the respiratory pump. So a lot of times when you're feeling faint, you don't want to take quick, shallow breaths. You want to just take slow, deep breaths. When you take slow, deep breaths, then you will get that respiratory pump working and get blood back up. Okay. Another part of physiology, as far as special physiology, when you are pregnant, pregnant women, they're going to increase their fluid volume and blood volume by up to 50%. And right now, in your body, okay, whether you're pregnant or not, right now, like in my body right now, the majority of my blood is actually in my veins. Okay? We have lots of veins, lots of extra veins. The veins are very compliant. They can expand and they can hold extra blood. So when you're pregnant, you don't have any extra room for that blood in your arteries or even your capillaries. So where's that extra blood going? All of that extra blood, that extra 50% of your blood, is going into your veins. So then you have the veins are going to be fuller, and this is the reason why sometimes women, when they're pregnant, would be more at risk to have varicose veins or spider veins, basically because the veins are being expanded a little bit more. And so what happens is if they expand a little bit past the point where the valves won't close, then you would have a little bit less venous return, and then the blood would pool in those veins and start to stretch and pull the veins apart. Okay. All right. So we have blood pressure related to gravity, venous return. Because you don't have a lot of pressure in the veins, we've developed the veins, and we have the respiratory pump to help return blood. Okay. Now, the last thing I want to talk about before we get into some of the lab structures is maintenance of blood pressure and blood volume. Okay. I want you to remember this for the rest of your life. Ready? Maintenance of blood pressure and blood volume is important. Okay? Just remember that. Maintenance of blood pressure and blood volume is important. Because if you don't have blood pressure and blood volume, you're probably dead. So you need to do this. And so you have, because it's so important, you have evolved several different methods to maintain blood pressure and blood volume. So there's a lot of what I call redundancy in maintaining blood pressure and blood volume. Okay? I have these things with the green arrows going up. These are all positive, okay, positively correlated with maintaining blood volume and blood pressure. For example, sympathetic system. Okay? Sympathetic division of the autonomic nervous system. Sympathetic stimulation is going to increase blood pressure. Okay? And that's one example. Okay? We have the endocrine system. Epinephrine, norepinephrine, similar thing, that you have these hormones are going to cause an increase in blood pressure. Okay. Then we have the renin-angiotensin-aldosterone pathway. Okay. The renin-angiotensin-aldosterone pathway. And you can see slides in your notes where basically it's kind of a complicated pathway. It seems like it's more complicated than it needs to be. But basically it's this. You have a hormone that is released by the kidneys. It's called renin. Okay? Renin is released by the kidneys when the kidneys sense low blood volume and low blood pressure. Now, remember, the kidneys, their job is to filter the blood. So if you don't have blood to filter, the kidneys don't have a job. So the kidneys, in order to maintain their job, is basically going to make sure that there's blood volume and blood pressure in order to actually work. The kidneys are very concerned about blood pressure because if there's not enough blood pressure into the kidneys, you're not going to perfuse and filter the blood. So the kidneys, if they sense that blood pressure is low, they release renin. Renin is going to cause the conversion of angiotensinogen, okay, which is a blood protein that's actually made by the liver, will convert the angiotensinogen into a hormone. It's called angiotensin 1. Angiotensin 1 then can be acted on by an enzyme. It's called angiotensin converting enzyme, otherwise known as ACE. Okay? Angiotensin converting enzyme. Angiotensin converting enzyme is found in the lungs. Okay? I don't know why it's found in the lungs, but that's where it is. And when angiotensin 1 finds the ACE, then it gets converted to angiotensin 2. Angiotensin 2 then can cause the adrenal cortex to release aldosterone. Then aldosterone has receptors in the kidney tubules that will basically reabsorb sodium. And when you reabsorb sodium, you're going to pull water with it. So then you reabsorb sodium, you reabsorb water, that's going to increase your blood volume. When you increase your blood volume, in your fluid volume, you're going to increase your blood pressure. And so this is kind of what this does. Okay? Another system we have is ADH and vasopressin. ADH, otherwise known as vasopressin, it's the same hormone. Okay? It just has two different names. They named it before they actually, vascular physiologists were saying, oh, there's a hormone that causes vasoconstriction. Renal physiologists were saying, oh, there's a hormone that causes reabsorption of water in the distal convoluted tubule and the collecting duct of the nephron of the kidney. Turns out it's the same exact hormone. It's released from the posterior pituitary gland. Vasopressin, so this ADH, and they call it ADH usually, except for when it has effects on the vessels. And so ADH is released from the posterior pituitary gland. Its effects on vessels as vasopressin causes vasoconstriction. That will increase blood pressure. Then you have ADH, its effects on the kidneys, antidiuretic, which means you're going to make less urine. You're going to hold on to more fluid, and that's going to increase your blood volume and also increase your pressure. Okay. Now, we have one type of, one hormone that does decrease blood pressure. So I have a little down arrow here. These all tend to increase blood pressure and blood volume. ANP. It's called atrial natriuretic peptide, and then it was called a natriuretic peptide when they found then when they found another one, they called it a B natriuretic peptide, and then they've just shortened it now to the official name is ANP, and there's a BNP. ANP is a hormone that's released by the heart, okay, by the heart atrium. When the heart is sensing very high pressure, it doesn't want to push against all that afterload, okay, if you remember from last chapter. So the heart can release a hormone that basically causes the kidneys to flush out sodium, and then water goes with it. That drops blood volume, will drop blood pressure. So it's kind of just a say self-defense mechanism that the heart has. If the pressure gets too high, it can release ANP to get rid of extra blood volume, decrease blood pressure, so the heart doesn't have to work so hard. Okay. The last one here can go up or down depending on which way the fluid is shifting. It's called fluid shift. And basically this is, if you get dehydrated, okay, you're going to have flow of interstitial fluid into the vessels, okay, basically osmosis. Or if you are well hydrated, then you would see flow going, blood fluid going out into the tissues. And so fluid shift can at least try to maintain blood volume when you have changes in fluid volume. Okay. Now, if you see all these up arrows, okay, and especially we have the adrenergic, or sympathetic here. We have renin-angiotensin-aldosterone with that ACE enzyme, and then we have ADH here. Basically, since we have multiple ways to raise blood pressure, we also have multiple ways to decrease blood pressure using drugs. And so people with hypertension a lot of times are on a combination of therapies. So for example, they could be on something like a beta blocker. Beta blockers block the beta adrenergic receptor, which is basically blocking this epinephrine, norepinephrine. So you can block that. Okay? You may have heard of an ACE inhibitor. An ACE inhibitor is going to, very, very common, very low side effects. Lisinopril is an example of ACE inhibitor. ACE inhibitor, it blocks this pathway. So then it keeps the blood pressure low because this is a way to increase blood pressure. And so if you block it, okay, ACE inhibitor, if you inhibit it, then you'd see the blood pressure go down. Then also ADH, antidiuretic, you can also prescribe diuretics. And then diuretics can also basically are doing the opposite of ADH. So since we have many ways to increase blood pressure and blood volume, because maintenance of blood pressure and blood volume is important, okay, we have many ways to treat blood pressure. Okay. All right, so that covers all the lecture physiology, lecture anatomy. Last thing as far as lab practical. So you have your objectives for lab practical, and basically here's what you need. You need to be able to identify an artery and a vein under a microscope. So I will have pictures of an artery and a vein. I'm going to post those on your weekly assignment. Okay, so you have an artery, you have a vein. And then the rest of the objectives are basically just finding all the different vessels. And so you can use your book and use your Blackboard self-enroll site. Okay, I'll put the directions up on week 3 assignments again to look at all the photos and labeled keys of all the different vessels. But mostly you would see here we have this wire vessels model. Okay, so the wire vessels model is very good to use, labeled out. Typically for the head and neck is kind of gets a little iffy here. So what we have is we have a good model of all your vessels of the, here are the arteries, and then you can definitely see in here the circle of Willis very nicely. So for circle of Willis, we'll use this. Then you have also in the head, you have venous sinuses. Okay? And the venous sinuses are actually thin like capillaries, but they're very large diameter. The venous sinuses, we actually have 2 different models here. Okay? And basically I can point these out to you. I already pointed the circle of Willis out. But right here, this spot right in here, it's called the confluence of sinuses. And out from here you have all the sinuses coming out. Now on this model here, which I call split head, okay, split head dude, basically you have from this confluence of sinuses going straight out here, this is the straight sinus. And then you have an inferior sagittal sinus here. Okay? And then a superior sagittal sinus here. So there are 6 sinuses that you need for your objectives. 3 of them are on split head. You have straight, inferior sagittal, and then superior sagittal. And And then we have this model showing all the transverse ones, basically, because right here, this little mountain right here, this little volcano here, this is your confluence of sinuses. Okay. Now, as you're looking at this, you're looking down. So this is down, inferior. So this right here, inferiorly down, is the occipital sinus. Let me show it to you like this. Okay. Okay. So, here's the orientation. Down, okay, occipital sinus. Here's your confluence of sinuses. Normally, you'd have a straight sinus coming out, and then inferior sagittal here. Right up here, this is the superior sagittal coming up. Okay. Then we have to the sides, okay, going laterally, we have the transverse sinus, and then we have the sigmoid sinus where it makes this curve. The transverse sinus, okay, and I can show you more of it here. Okay. The transverse sinus is going to be over the occipital. And then when it goes over the temporal, okay, right here, now that's going to be the transverse sinus there. Okay. Or sorry, parietal. When it goes over the parietal and temporal, then it's the sigmoid there. So it's transverse, and then it's sigmoid. Down here, occipital here. So we have three sinuses for the venous sinuses. Okay. All right. So artery and vein. We have circle well as venous sinuses. For the fetal circulation, you saw that also. Your models, major models for the blood vessels are going to be, you have this wire model, okay? And so I'll have pictures of the wire model, have that keyed, very similar to your the Blackboard Bio Study Lab, and I'll give you another link for that to study from. And then also this G30 plaque here. Now this plaque here, not quite as good as the wire model as far as finding all the vessels, but one of the things that this does is very helpful when you're trying to look for vessels where you have the same tube and then it changes names, okay, without splitting. For example, on the wire model, you have an external iliac artery that then becomes the femoral artery that then becomes the popliteal artery when it gets behind the knee. Now it's iliac when it's inside the body cavity, femoral when it's in the leg, and then popliteal when it's behind the knee. You don't have the bones, you don't have the skeleton to find those points. So you need this one so that you can see external iliac, and then it comes out and then the hips into the leg, and then it's femoral, and then when it's behind the knee, then it's popliteal. Okay? Same thing happens with the arm, where there's really no good marker for your subclavian to axillary to brachial here, okay, for the vein, or even here it's even worse, subclavian, axillary, brachial. You don't know where they start and stop, but then on this model here, okay, you go here, you have subclavian till it hits the shoulder. Then when it's under the shoulder from about here to here, when it's in the armpit, then that's axillary. And then when it's actually on the humerus right here, then it's brachial. Okay, so it's helpful to have the skeleton on this one, so you can find those vessels. Okay. All right, so that basically finishes up everything I want to talk about for Chapter 21. Make sure you watch this video, answer the questions, your weekly assignment, and then also you need to read the PowerPoint notes and study the PowerPoint notes. I'll put a link for the lab materials that you're going to want to study this week. All right, so then next week we'll have week 4, where we're going to do lymphatic, which is a pretty short chapter. We have week 4. We also have the blood pressure, pulse, EKG, and lymphatic labs, and then you should be studying that week for your test the following week, test 1. After test 1, then we'll get it back, and then I will go over, since you've had a whole section of material and you've covered these chapters, then if you'd like to get started on your paper from one of those chapters, then you can go ahead and start getting that together. So then I'll have the rubric for that paper. All right, thank you very much. Have a good week. Looking forward to your assignments on Sunday.